Clinical documentation improvement for the inpatient coder. The interest in clinical documentation improvement came to the attention of chief financial officers across the country with the implementation of the inpatient prospective payment system in the early 1980s. Suddenly, the content of the documentation in the medical record was linked to the hospital's reimbursement. The content of the documentation was not in question in regards to the payer requirements of the legal medical record. The change in the documentation was the diagnosis language. Suddenly, documentation of unspecified diagnosis put a hospital at risk for a decrease in reimbursement. So the industry was tasked to educate the physicians to document the patient's diagnosis that would generate a code with specificity. The hospital's financial sector had a difficult time getting physician buy-in to change their documentation. The physician's documentation was perfectly adequate for clinical care. The physician's professional fees would not increase if they changed their documentation habits. Therefore, the hospitals had to find a way to help the physicians improve the change in their documentation. The industry decided nurses would be the best choice to educate physicians about the new documentation requirements. The industry reasoned that nurses were the only ones who had the confidence to interact with physicians face-to-face, and they could think clinically, unlike an inpatient coder. But the industry failed to recognize a big problem. Nurses didn't understand the GRG payment system. Consulting companies across the U.S. designed a solid, very expensive clinical documentation improvement programs to the hospitals. The programs consisted of teaching nurses the basics of the DRG payment system and the documentation clarification process. Nurses put down their nursing hats and began to read medical records. They then attempted to build a base DRG and then look for query opportunities. Early attempts were not very successful. Coders were inundated with phone calls from nurses with diagnosis and procedure code questions, coding sequencing questions, and diagnosis code lookup. This was the first sign the industry got it wrong in regards to who would be the best candidate to perform CDI review. If nurses were the best choice, why was it necessary for them to consult the coders? Then came the DRG mismatch. As nurses gained confidence, they assigned a base DRG. Then they wrote queries of what they believed had an increase in reimbursement, only to find that they had selected the wrong base DRG. In many cases, when the base DRG was incorrect, the query they had written in did not have an increase in reimbursement. Once the coders corrected the DRG, we at Evernorth CDI have always believed that the coder is the best candidate to perform the duties of the clinical documentation improvement staff. The inpatient coder has years of experience in regard to the complete medical record and is fully knowledgeable of the content of the record and the location of the documentation. In addition, the inpatient coder fully understands the DRG payment system and assigns 15 to 25 DRGs per day. No other individual knows the diagnosis and procedure code set better than the inpatient coder. Additionally, inpatient coders who took coding courses also passed anatomy and physiology, pharmacology, and pathology as well. So the argument that coders cannot think clinical does not stand. The industry changed once again with the implementation of the electronic medical records. Physicians no longer sit at desks on the hospital units documenting in the paper record. They're back at their offices or homes documenting via their computer. Therefore, the process of face-to-face physician interaction has become virtually impossible, and even more importantly, an unnecessary disruption to their valuable time taking care of patients. Due to the implementation of the EMR, the electronic query has become the standard of practice. There is just one task that needs to be completed to take the inpatient coder to the next level of clinical documentation improvement staff. This task is the concept of the Evernorth CDI Academy. We have developed 15 modules for the inpatient coder to further educate them in seeing the unspecified diagnosis in the medical record. We will walk you through the information to look for in the medical record that will validate or rule out a query opportunity. The information you will learn to look for are the clinical indicators, diagnostic tests, and therapeutic treatment of each of the 15 diagnoses. Once you have completed the 15 courses, you will be fully prepared to write and send a relevant query.